Good morning and welcome. I am Melinda Santiago. I'm the Director of Behavioral Health here at KHS, and joining me today are Courtney Morris, the Behavioral Health Manager, and Rafael Juarez. He's our Licensed Care Manager. We may also have additional KHS staff with us. I know we might have extended this to your assigned provider reps. So if there's anyone from KHS that wants to introduce themselves, you can do so now. I can't see the screen since I'm sharing it, so.
Hi, good morning, everyone. My name is Estella. I am one of the provider relations representatives. Thank you so much for joining us today.
So I just want to start off by just thanking you for taking the time to participate today. The recording, along with the presentation and the handouts, will be made available on our website under the provider tab. So if any of you are familiar with that or need assistance, we can definitely do that towards the end of the training. Today marks the beginning of a new quarterly training series designed to support our providers. These trainings were developed in response to trends identified through our Q1 chart reviews and audit findings. Based on these insights, we created targeted support and guidance to help strengthen documentation and ensure compliance and promote high quality clinical care across our network. And so I just wanted to start off by saying that, and then we'll go into the goal for today. So the goal for today in this training, I just kind of put the objectives there, is to understand the role and requirements for our non-specialty mental health within the Medi-Cal, recognize the importance of a comprehensive assessment in establishing medical necessity, maintaining high clinical documentation and care standards, identifying key DHCS requirements. I wanted to talk about a new APL that came out. It's an all-plan letter that more or less, for those of you who aren't familiar with all plan letters, they are guidance based on regulatory requirements from the Department of Healthcare Services, who oversees our contracts. And this one is specific to trauma screening for our youth and in regards to our youth. So describe appropriate clinical actions when trauma is identified, including when to refer to specialty mental health services, understand the transition of care tool, processes, care coordination responsibilities, and your role as a provider and all of that. Identifying key requirements related to credentialing, billing, documentation, audit readiness for non-specialty. So that's hopefully what we'll cover today. At any time, I do not have, I cannot see anybody on camera. I cannot see hands raised. So we're going to have Courtney and Rafael kind of, if they see a hand up or, you know, a comment in the chat, you know, they'll go ahead and kind of let me know that, and then we can go ahead and stop for that. We want, hopefully, this to be interactive. So throughout any of these slides, if you have questions, please don't hesitate to ask them. And of course, at the end of that, we'll go ahead and have opportunity for questions as well. So on this slide, it just kind of breaks down the provision requirements. As a managed care plan, KHS is responsible for making sure non-specialty mental health services are either provided directly or arranged for our members. So for our adults age 21 and over, services are appropriate when individuals are experiencing mild to moderate distress or functional impairment. And we'll go into that as we progress in the training. So those symptoms should align with recognized mental health conditions supported by the DCM and the ICD. criteria, and for children and adolescents under 21, the standard is a little different. These specific services are covered under EPSDT benefit, which means services are provided regardless of the level of impairment or whether there's a formal diagnosis. So this allows for early intervention. It's broader access to care for our youth. And across all ages, we can also provide services to members who may have suspected or undiagnosed mental health conditions. In these cases, services can be focused on the assessment and early intervention and prevention, not just treatment. So this slide here is a quick overview of what's included under non-specialty. And at a high level, non-specialty services covers a wide range of outpatient behavioral health services. This includes, of course, the mental health evaluation, ongoing assessment, which is really the foundation for identifying needs and establishing medical necessity. It also includes individual, group, and family therapy. These are the core services. Most of you are providing them day to day. You may also see dyadic care services, which focus on the caregiver and child relationship, especially in early childhood. This is more for those in the rural integrated medical facilities like the rural health clinics, the FQHCs. You're going to see the dyadic services being done there. In addition to psychological testing can be included when it's clinically appropriate. But it's not required in every case. There is also medication component, including psychiatric services for medication management and monitoring. And in some cases, outpatient labs, supplies, supplements are included when they support overall treatment plan. And then on the next part of this slide, in terms of who can provide these services, there are a few different provider types. So at one point, under MCP and coverage for non-specialty, it was very specific to, LCSWs and psychiatrists. Now, it is allowed to have, the LCSWs, of course, LMFTs, LPCCs, psychologists, psychiatrists. These individuals can provide services independently within their scope. Then there are the associate level providers, such as, the ASWs, the AMFTs, the APCCs, who can also provide services under supervision. So it's under the licensed clinical supervisor, and so we'll talk more about that in terms of how they will be documenting and billing and all of that good stuff. So, and lastly, primary care providers in an integrated care setting who can conduct mental health assessments and provide the other services included in the non-specialty mental health benefited covered services. So if they're not able to provide full scope, the expectations that they're going to refer out our members to a non-specialty mental health network provider who can ensure appropriate care. This is kind of where we get into what we are looking for, and so the clinical assessment is really the foundation of care. It sets the stage for everything that follows in treatment. First, it's what allows us to establish medical necessity. Without a clear and thorough assessment, it becomes difficult to justify services. So it also guides diagnosis, treatment planning, helping ensure that the interventions we provide are appropriate and targeted. A strong assessment helps identify any co-occurring conditions, such as substance use or other mental health concerns that may need to be addressed. So And importantly, it helps us determine appropriate level of care. So whether a member needs can be met within non-specialty, or if a referral to specialty mental health services is needed. So in terms of what needs to be included, we do get questions about that, and so I just wanted to kind of cover just key components of that, and really wanting to clearly document the presenting problem, complete a mental status exam, a risk assessment, is there critical uh, it's critical. So including concerns related to suicide or homicide. You should also, assess functional impairment, how it ties directly to medical necessity. Screening for substance use is important, along with the trauma screening for the youth. This is in regards to the alignment with the new APL requirements, which we'll talk about in the next slide. And finally, just really making sure that cultural and linguistic factors are addressed here. These can significantly impact, engagement and treatment outcomes. So that's kind of just making sure that the assessment supports all of these areas, just so we can ensure that they're getting the right care at the right level, is really the importance of the clinical assessment. This slide really outlines, and I've had providers ask, do you give templates? Do you give anything, even when it comes to the assessment or when it comes to session notes? And we don't. We often allow the providers to use whatever tools that they currently use. However, we do have some that we have now kind of come up with that we can kind of discuss, and if you want to kind of review those, we can definitely do that and have further discussions offline for those of you who do. But this slide specifically, just outlines what should consistently be included in your session notes to support both clinical and quality and medical necessity. So there are many templates, like I said, some providers use SOAP notes or DAP or BURP, but just starting with the basics, every note should include the identifying information, and that should be the client name, the member ID, date of service, duration, modality, the diagnosis. From there, just clearly describing the presenting symptoms. This means being specific about the frequency and intensity and duration, not just general statements, but including any updates the client shares, and really including the objective observation, such as appearance and mood and affect and behavior, any relevant mental status findings, and it just kind of highlights other areas like the functional impairment, which is a key piece for medical necessity. You want to show how symptoms are impacting the client's daily life, whether that's work or school or relationships, and include concrete examples. This can move into interventions provided. This is where you demonstrate your clinical skills. It's important to document specific techniques used, not just that you talked or that you provided support. And you should capture clients' responses. So how they engaged, whether they showed progress, if there were any barriers or lack of change. Make sure the session clearly connects back to the your treatment goals, your plan, right? And your assessment of progress should be included in like the clinical interpretation, and just are they improving, staying the same, declining, things like that, and really finally the plan for next steps. What will you focus on, anything like that. So and when needed, just risk assessment, if there if you need to kind of address it based on that. So that's kind of like high level what should be included in session notes, and what we were finding in the chart reviews, and making sure that those elements are there when we are asking for, records and things like that. The next slide is really just highlighting, when we talk about medical necessity, there are a few elements that always need to be present. First, there needs to be a mental health condition. This means symptoms that you're documenting should be consistent. The level of distress, functional impairment. For non-specialty, this falls under mild to moderate range, right? So it should be impacting the members' emotional, behavioral, social functioning at a mild to moderate level. Anything higher than that, that's where you're looking at the transition of care, for a higher level of care. So the next is the need for treatment. There should be a clear expectation that services you're providing will kind of help improve or stabilize. And so also just the need to ensure that the member is receiving the appropriate level of care. So that's just to ensure that we're able to support them at the right level. So additionally, all of this must be supported by the clinical documentation. So your assessment should be clearly justify the type of frequency and duration and services you're providing, and so hopefully that'll make sense in terms of just documenting the clinical rationale and linking the symptoms to the impairments. This is where we're highlighting the APL requirements, and this the APL. This is not a new APL. There was a previous APL back in 2022, and it is the APL title is the Medi-Cal Managed Care Plan Responsibilities for Non-Specialty Mental Health Services, and it really just highlights all of our responsibilities and expectations. And the updates, though, for this one is it's focused and related on the trauma screening requirements. So they will review that on the next slide, but I just want to kind of give general guidance on non-specialty covered services, and even prior to establishing like a formal diagnosis. This includes, medically necessary and clinically appropriate services delivered during the assessment and the psychiatric evaluation process. So that's the first step, right? The second is services do not explicitly need to be documented like in an individual treatment plan for those services to be covered, but services need to be clinically appropriate and fall within assessment, prevention, treatment activities. It remains a covered benefit. So this does not remove like clinical expectations to demonstrate treatment direction. All of that still needs to happen. The third is I'm just kind of summarizing this long APL, is kind of coverage that applies when a member has a co-occurring substance use disorder. This includes situations where members are also receiving services through maybe the drug Medi-Cal organized delivery system. That's, for those of you may know it as, Kern Behavioral Health and Recovery Services. They have the DMCODS. They're the administrator over that system. So there can be individuals who are open both to substance use and still meet requirements or criteria for non-specialty mental health services. And you can also have individuals who are open to non-specialty mental health services and also open to specialty mental health services. Services can be provided concurrently. when clinically appropriate. So that just involves, making sure that we're really monitoring for duplication of services and that we're really doing that care coordination between the two systems. And so they want to make sure that is happening. And when I say they, I mean DHCS. So they just want to make sure that that we're flexible when it comes to the approach of care, that the members have a right to decide, what system of care they use without it being, delayed or us restricting or us denying them based on really anything. And so just making sure that we're providing those services and not giving our members barriers or creating barriers for them. This is kind of where we talk about the trauma screening requirement for our youth, and this is very specific to that. So the APL went live or went into effect April 1st, and in preparation for this update that went into effect April 1st, we went ahead and we sent out a provider bulletin. I believe it was like March 13th, and it outlined the DHCS approved youth trauma screening tools. And for those of you who did not receive the bulletin, I know it went live, and I know we've also emailed it in addition to faxing. For those of you who have not received that, you can go ahead and put it in the chat, or you can reach out to us in email and we could always just send it to you. But under this requirement, providers are expected to conduct trauma screening for youth and children, an adolescent. So children and adolescents, when clinically indicated and or a part of the clinical assessment process. So this supports early identification of trauma exposure and are related to behavioral health needs, as well as informs potential specialty mental health access determination. So screenings must be completed using the DHCS approved trauma screening tools. So they've more or less highlighted, and I'll put that on the next slide. It has a list of all of the trauma screenings that DHCS approved, so that we maintain compliance with state requirements. When tools are used, providers must apply the standard scoring methodology. They and ensure that the results are interpreted appropriately within the clinical context. So all screening results must be clearly documented in the medical record, and including both the outcomes and any clinical interpretation that informs next steps in care, including whether further assessment is needed or a level of care evaluation is needed, which will then result in a transition of care. Just when trauma is identified, or when a screening result or a clinical presentation indicates concern, providers are expected to initiate appropriate follow-up, and that it's documented, which may include, I just said, referral to the specialty mental health side. And in addition to that, providers should coordinate with other systems. Really, it would probably be, with us or with the specialty mental health side, but it can include schools and child welfare system or other agencies that are involved. So just the other thing about the trauma screening is just making sure that it's age appropriate, and culturally responsive and developmentally sensitive, ensuring that the approach matches their cognitive and emotional development. So that was just something that was highlighted there. This is the list. So this slide more or less is a complete kind of list for those. Providers must utilize either of these. But I did want to highlight that it's important to note that not all the screening tools are reimbursable under the Medi-Cal ACEs screening benefit. So I know that for those individuals who bill for these, I know it's more done at like the PCP level, more than likely your screenings will be done within the assessment process. So I just wanted to kind of highlight that the ACEs questionnaire and the PEARLS, that's the Pediatric ACEs Related Life Event Screener, those are the ones that there are specific billing codes for that can be billed. But there are all the other list of those that you may want to, or that you may already use, or that you may want to consider using as part of when you determine that it's appropriately needed. So this just kind of talks about when trauma is identified through the screener. First, providers must conduct a more in-depth clinical assessment. This includes further evaluation of the trauma history and related symptoms to better understand the clinical picture. Next is just to evaluate any co-occurring or related conditions, such as PTSD, depression, anxiety, things like that. And then the safety and risk assessments need to be completed, including consideration for any immediate risk or safety concerns. From there, the providers should determine the appropriate level of care. So including whether services can be effectively managed within the non-specialty mental health, or if it needs to be referred out to specialty mental health services. So that's just based on clinical findings, and that's done through the assessment process. And so I just kind of put on here possible interventions that can be used for this.
And Melinda, just to add, because if the member was deemed appropriate for a higher level of care at the specialty mental health side, this would be a referral through the transition of care process. So just for clarification, because they should not be referred directly to the specialty mental health plan. You should use the transition of care tool and follow the transition of care process, which Melinda will talk a little bit later about in the presentation.
Thank you. Yeah. This next slide here is when to refer to specialty mental health. And so I know sometimes questions come up with when they should be doing a transition of care tool, when someone should refer to specialty mental health. And so I really wanted to just highlight it has to do with, the severity of the mental health symptoms. A referral should be considered when symptoms indicate an SMI or an SED, and really this is where those symptoms exceed the mild to moderate impairment. So it's not just the diagnosis in itself. It is not that if an individual has a diagnosis of schizophrenia or bipolar or a substance use disorder diagnosis, it has to do with their level of impairment and whether or not it's appropriate for non-specialty. And so, that kind of goes down to the significant functional impairment. Is there major impairment in their daily functioning, difficulty maintaining school or work performance, significant disruption in family or interpersonal relationships, inability to manage self-care, independent living activities? Those are some of the areas, and it's based off of their mental health condition. So, and that's the tie-in, right? So the need for a higher level of care. Some members require more intensive services that are outside of non-specialty mental health services. So this may include intensive outpatient structured services, individual rehab, group rehab, those ongoing case management support services, which we are not allowed to bill for. That's outside of our scope. or our benefit covered services, intensive care coordination, crisis intervention, home-based and community-based intensive interventions. Those are all things that if an individual, through your treatment, through your assessment, you determine that they need these level of care, then that is where, it would be appropriate for you to be able to transition them on. And I'll talk about additional services and full transition on the next slides. Safety concerns, immediate referral to specialty mental health services. And I'm not saying like this is kind of where they, it would be very intensive services for a period of time. There are times where you're in treatment with an individual where they may go through cycles of needing that, maybe a little bit more services, maybe needing to see you with more frequency. That is okay. But when it is coming to the point of that, their suicidal ideations and their behaviors are putting them at risk for a psychiatric hospitalization, or they're in acute crisis of, ongoing or just for longer periods of time, this is where you're really looking at. They may need additional services that are outside of what you're able to give them. And it's not just that, they want to be seen one time per week. That's not what specialty mental health services is. It is that they need those other intensive services. So they need that specialized and intensive treatment, like the intensive home-based services or therapeutic behavioral services, intensive care coordination, those type of targeted case management, individual and group rehab services, all of those services that are that wouldn't be able to be kind of met through your individual or your family or your group therapy. Then if they need those other services, then that's where you would kind of look at specialty mental health, because it's based on severity, it's based on functional impairment, safety risk, intensity treatment needs. That's when, non-specialty mental health services is no longer sufficient to meet the member's clinical needs, is really when you need to consider that. So here's where we talk about the transition of care. It applies when there's a need to ensure continuity of care between the delivery systems. This is not just about changing providers. It specifically applies to when we're coordinating care between the systems, when a member is moving between non-specialty and specialty mental health, when there's coordination needed between the MCP and the MHP. That's the mental health plan, or now it should be called BHP, because it's called the behavioral health plan now, and that's the Kern Behavioral Health and Recovery Services and all of their contracted providers. When a member is receiving services from both systems at the same time, it's consistent with no wrong door model, concurrent care expectations. So it can be both sides, or when clinical needs require coordinated movements between the levels of care. So that's really what a transition of care tool is for. It's not just like an internal change of provider within the same system of care. So, if you're changing from one provider to another, that is not what a transition of care tool is needed for, because that's just a change of provider within the same system. The transition of care tool, it primarily just communicates, and it's standardized. So that's why DHCS more or less created it and mandated us to use it back in, 2023, I believe it was, that they created this tool, just like they created the DHCS screening tools for us to use. They really did it to support safe and timely movement of members between the delivery systems. It just helps ensure that important clinical services and information shared between the MCP and the MHP is done in a consistent kind of format, so the receiving provider can continue care without disruption. And it's used to support referrals and transitions to make sure that the receiving system has the information needed to appropriately continue services. And so what the TOC does not replace, it does not replace the clinical assessment, because the clinical assessment is really what drives the level of care determination, right? So the transition of care tool should stand alone, but it should be based off of the clinical assessment. It does not replace emergency or crisis response. It doesn't replace EPSDT service requirements. It does not replace the provider change within the same system of care. So it really is a coordination tool that helps support the transition between the systems when clinically appropriate. And that's why I think what we really wanted to focus on, just emphasizing the clinical assessment, because I noticed, or we notice sometimes when we are seeing that there are times where a transition of care tool can go back and forth between the systems. So, we'll have one of our providers complete a transition of care tool. We send it over to the other system. They complete their assessment, and they determine that they don't meet criteria for specialty mental health, and then they're sending it back, and it just it ping pongs. And so we really want to make sure that we're looking at reinforcing our assessment process and our documentation for our assessment, so that it can really support the transition of care, and we kind of avoid these delays of getting our members into the right system of care. And so we really just want to strengthen that process. And this one just talks about our responsibility. We have the responsibility to ensure continuity of care and just coordination. So even though we do the transition of care, there's no interruption in services. We continue providing those services until the transition is fully completed. As the MCPs, we're responsible for ensuring timely transfer. So that's why it's important to make sure that, when it comes to us, we review the transition of care tool, and then we immediately send it off to the county. They have an entire department that's the care coordination unit that it filters through. They're the gatekeepers of all the transitions that go to them and from them. And so we're the gatekeepers on our end for the behavioral health team to ensure that we're able to track all of these transition of cares, all of the initial referrals, all of them. So it's really important for us to kind of make sure. And so when we see that a transition of care tool is missing elements that's going to ensure that they get linked, we're oftentimes trying to reach the providers, kind of going back and forth with that. And so it's really important for us to have access to the providers directly, because you guys are the ones with the expertise. You guys are the ones that made that decision or completed that transition of care tool. So sometimes when we're not able to have those conversations with you, it definitely causes delays, and it just makes it harder to get what we need. And so we really just are here to provide that support. Member engagement is really important in this process. It includes involving the member in the process, and just making sure that we're obtaining that consent of just them knowing that it is happening, so that way we can do those warm handoffs when appropriate. And I know that's something that we've asked for on the specialty mental health side, when they're stepping down, making sure that it is appropriate step down. It is not because that individual is disengaged in treatment. That is not what an appropriate step down is for. And so we are really careful when we're looking at those step downs and why it should be filtered through us, because we're here to kind of support our network. And when we see that maybe we're bypassed, where maybe a specialty mental health treatment outpatient team goes directly to you and bypasses the transition of care tool and just sends the member over to you. That's different. That's not no wrong door, because they're opened already. They're in treatment. No wrong door is really intended for those individuals who are not currently open to any system of care, and they could go to any door and not be turned away. These individuals are currently open. They are currently engaged in treatment or not engaged in treatment. And, we want to just make sure that it isn't just, well, they're not engaged with us, so we're just going to give them to a non-specialty team, because what's going to end up happening, individuals will oftentimes decompensate. They'll end up in crisis. They'll end up in hospital or in the PEC. And so these are things that we're really trying to avoid. So really making sure that if you are receiving these referrals or these kind of requests for step downs from a non-specialty mental health, from a specialty mental health team, from a county team, that you're really redirecting them back to the process, because this is a process that DHCS has more or less, it's required on both systems of care. So this is really just to ensure appropriate coordination between the systems. So we really need to make sure that both sides are following this process, so that way it's successful. And so we just want to make sure that the members are connected and receiving the appropriate care at the right level. So I think that's pretty much what I want to say on this slide. This slide is really going back and talking about credentialing requirements, sorry. And so for the associate levels working within KHS network that are specific, that we have specific credentialing requirements in order for them, that need to be completed before they're delivering or billing services. This actually goes for licensed individuals as well. We do notice that there may be a contracted agency that's contracted, but not every single one of their licensed staff have gone through the credentialing application process. So it is important for every single one of your providers that are providing services to our members that they have gone through and been approved through the credentialing department. And the way we can see that is, and I'll talk about it on the next slide in terms of how we're looking at billing and kind of what's essential and where MPI numbers should be at, so we can accurately track billing. So I just want to say that also all associates working under KHS are working under a licensed provider, and that we have rosters that need to be submitted at a minimum on a quarterly basis. And if changes happen, because changes often happen, if you want to submit them on a monthly basis, you can go ahead and do that as well. But at a minimum, at a monthly basis, just to make sure that we have a list of all the associates that are working under, and then also a list of all the credentialed, all the licensed individuals. So that way we can actually see, oh, there's someone that didn't go through the credentialing application. Go ahead and do that. So then that way, the other thing too is that it might change the rate of reimbursement, because if you're a non-PAR, if you have not gone through the credentialing process and been approved, you're going to be considered a non-PAR provider, even though you're under a contracted, even though you're working within a contracted agency, because you're not credentialed, and that changes rates for reimbursement or rate payment that you're going to be getting. So all of that's really important. So I just want to make sure that you know that we have a centralized roster for all associate level providers. And so for those of you who have not seen the roster for that, please let us know. We will definitely send that out. And I know that we submitted or we had sent out a provider bulletin for that as well. And so I don't remember when, but if you haven't seen that, please let us know, and we will definitely provide you with that. This is making sure that the credentialing department is notified with any updates, any changes to anybody who's serving our members. And let's see. I just wanted to kind of highlight too on this slide that associate providers are not individually loaded into our claim submission. And that's why when we talk about how an associate is going to be submitting claims, that they're going to be submitting it under the licensed person, it's because they don't work independently, right? So I'll be talking about that on the next slide. Let me see, anything else I want to, I mean, they're all the key points there on the bullet. So let's try to see. This is the billing. So all of you guys should be familiar with this section here. And so when submitting claims for services provided by an associate, it's important to follow the specific billing requirements to ensure that you're accurate when submitting, you know, when you're processing for processing. So first, the associate clearly documents on the claim. This should include the additional claim box. So on box 19 right here, where it has the information of the name. And this is where we don't need their MPI number because they're not billing separately, but their name, and that's where we match it with the roster. So the next area is the licensed supervising clinician's MPI. That must be entered on line 24. That's 24J. So it is right here. This got cut off. Oops. So there's that. The providing NPI information where you can, box 32 and 33 are the group NPI only, but you should not be submitting claims under the group. There should be a specific, you can include that, of course, because that's how we know where you're associated with, who you're associated with, but you as the rendering provider, you're the one that's rendering it, and it should be very specific to that. So we can take any questions when it comes to that, but I kind of just made sure that we highlighted some of the areas where they're really important, which is just making sure that box 19 has the associate provider name, box 24J has the licensed provider, and 32 and 33 is the group information. So this just allows us to kind of, when we're capturing, when we're doing chart reviews and audits and all of the billing reviews, we're able to kind of really look at that. So this just kind of, as we're winding down, I wanted to kind of just reemphasize, you know, best practices just to ensure compliance with DHCS requirements and our KHS audit standards. Documentation must be consistently documented with clinical clarity, medical necessity, care coordination, or, you know, coordination of care efforts. All of that is in there. Clearly documented screening tools specific to the DHCS approved screening tools. And so it just kind of talks about all of those requirements for that. The next area, this slide, when we were doing chart request or records request for our chart reviews, we really wanted to highlight in this training just all of the area that should be in a member's record, and what's expected based off of DHCS and our KHS standards. There should be an access and intake area, and this really documents clearly it captures when the request was made. We're required to track for urgent or routine referrals, being able to ensure that we're doing that we're able to meet the timely access standards. And so you should also kind of have that in somewhere in your records. You should have an intake section for consents, being able to have those informed consents, the HIPAA acknowledgements, the releases of information, all of that stuff should be part of the chart record. Clinical documentation, the mental health assessments, the screening tools, the progress session notes, psychological evaluations, medication consents, just anything and everything that goes with clinical documentation should be in this in an area in your record for that. A medication, if you and this is not just for psychiatric providers, but making sure that if you're aware, as a clinician, if your members are on medications, being able to document that and knowing what medications they're on, who their treating psychiatrist is for care coordination efforts, all of that stuff is really important to have in there. But for those who are providing psychiatric services, making sure that you have a section for your medication management session notes, your consent forms, all of the stuff that needs to be in there. For that telehealth, if you're providing services through telehealth, making sure that telehealth consent forms are on there, and all of those areas that need to be addressed in those sections. A coordination of care section, if there is psychiatry that's outside of your panel, or the vice versa, if you're doing psychiatry and you don't have therapists, vice versa, it goes both ways. But care coordination with the primary care provider is really important. Being able to document, the social determinants of health, or referrals to substance use, referrals to, maybe these individuals need community support services or ECM services. This is all things that you would be doing in the care coordination, or the care coordination of care section, just documenting those type of referrals that you're doing for your member, or the client that you're serving. Other areas, language, how the services are being done, if you're needing translator services, if you're using translator services, if making sure that your forms are in Spanish, if you're treating somebody that's a Spanish speaker, just things like that. And then the thing that's really important for health equity, and we're starting to do that as well, is the sexual orientation and gender identity. So it's the SOGI. And that's just making sure that we're being responsive to how a member wants to be referred to, and just making sure that there's documentation related to that in the assessment or in session notes, or something in there that really helps with, so that we're consistent with the member's self-identification. So those are kind of the key areas that are really important, that are required for a chart records to have for mental health. And the next slide is really just putting faces to I wanted to, take a moment just to put our faces to our names, share our contact information, our email, just so that way you guys can reach out to us. Many of you have already been communicating with us through email or phone, so I just wanted to make sure that it was somewhere on there. And then I also wanted to make sure that we had contact information for our team. So if you need support, clarification, just any assistance from our behavioral health team, and this falls under the mental health services, the substance use services, ABA services, you can reach us. We have specific emails group emails for general behavioral health or for ABA services. You can kind of see that there. You can have our number. We don't have a direct line for external use, but we can be reached by selecting option 7. And I just want to say that we are here and available to provide any support that you may need, any clarification. And this concludes the presentation portion today. And I just want to take a moment to thank you again for the time, your engagement, your continued commitment to just strengthening clinical practices and documentation within our network. And at this time, we'll open it up for any questions, comments, clarifications that you may want to have. I'm going to close this part though, so I can see people